First off, quick apology. I just went in the my email queue. I had all the notes sent out to you guys on Monday for this Zoom lecture, but I saw them sitting there in the draft queue that weren't sent. So my guess is none of you received that email on Monday for the stuff we'll be doing today. So that one is on me. That's the bad news. The good news is you had an easier week. And I'll have to be nicer to you today too. So there's some good news in there. Except for Patrick, because I can just do what I want to Patrick.
Yeah, first Zoom back, we can pick on me, I guess.
Yeah, make you feel like it's home again, you know? Yeah, this will be very comfortable. Really what I sent out this week was the first Zoom session is one that was kind of from the lumbar one, but it works really well here as well. And we've done this a good bit, but it's always worth doing is differentiating pain. Jim has some very nice lectures and thoughts on where he goes over it. And in this attachment I've sent you just now, two good articles on it. Again, one is a case study, just reviewing it. I think it's a nice way to frame your mindset, and we'll kind of go over it a little bit kind of today. We'll also add a little bit to the notes that I've created, for that, looking at different cases. We'll look at a lower extremity case, and we'll look at an upper extremity case, differentiating, nociceptive, referred, radicular, neuropathic pain, and then I also included some topics there on central sensitization, since it's super in vogue right now. I don't think we see as much of it as they've kind of led us to believe that we would see. And it's kind of the current kind of model that's gaining traction. But it's good to know in there because we have that discussion, or if you're like just the way you've come up, it's been like, hey, you're thinking central sensitization earlier than you should. That's fine. But it's just nice to have that self-bias correction. Understand when I think, okay, I think this is central sensitization. Let me go back and look at these other buckets as well. Or can I identify the stressor which is causing the central sensitization, be it a segmental dysfunction, an instability, basically ligament or tendinous strain? What's the genesis for this? And can I treat the cause to eliminate the neural windup? I'm just trying to share my screen. Can you see my screen now? I'm guessing yes.
Hey, Dave, before we get started, quick
Absolutely.
question.
Yeah, shoot.
So I work with professional dancers, and I was actually there today with them. And one of them, I was actually using the lumbar skills we did in our lab. And one of them was stuck in flexion throughout the entire lumbar segment. So like L1, 2, 3, 4, 5, all on the left. Would we like mob and even potentially manipulate in the same way that we did that single segment, or is there a different technique for that? Because like I said, she was doing a lift, like some partner work, and got shifted weird, and now her entire left side is stuck in flexion, and I was having a hard time trying to get her in a better position.
Yeah, I mean, if you're looking at multiple segments, it'd be really rare to have all multiple segments there. There's probably a key segment that is, and the rest of it is myofascially kind of toned up. So for that individual, when I'm finding multiple segments, I'm thinking, okay, there's got to be a larger source to this, whether it's a key segment or TL junction being knotted up or something else that's causing this to happen. I would, as a treatment, look at the sideline techniques, and I would do, you can think about it in layers. I have the joint layer where I can mobilize the joint. You can also do, shortening and lengthening of QL, the obliques, or the muscles to put the muscles in a shortened position to see, can you get them to reset? So joint mobs, and you're looking for that proprioceptive down ramping of what the hypertonicity, I would approach it segmentally, just to practice segmentally. It can be done as more of a general technique just to see, can I get this system to unwind? Also, if you put them in that sideline position, get those muscles adaptively shortened. Can you get them to reset? That's the first thought to the top of my head. I'm sure Eric has some thoughts on this.
Yeah, I mean, my first thought.
So I put.
Sorry, you have another question?
So I put her in. I did. Oh no, what I was gonna say is I put her in, so I did like mobilization segmentally, and then I did put her inside. And I love working with dancers because they're so in tune with their body is telling me, she's like, Lizzie, this feels good. It's helping with the pain. I just continue to feel stuck. She's like, that didn't solve the problem. I feel stuck.
Mhm.
Yeah, I would agree with Dave. My experience is that the odds of having multiple segment sublux like that's pretty rare. The example that I always see is, I'll see this, and I see it a ton, is if I'm looking at somebody's cervical spine and they feel like they're really stuck on one side, like they couldn't close their right side, and I'm going through and I'm doing my pivums and pavums and every segment feels jammed. What I've started to notice with that is it's actually an overlying myofascial issue where the scalenes have contracted and they're basically kind of crimping the side closed so it just doesn't allow any movement. Um, and so that tends to suggest that it's an upper thoracic issue as opposed to a cervical issue that's creating that restriction. So my first thought would be a similar sort of situation here where you have overlying motor tone issues, probably descending from either the TL junction or someplace in the thoracic spine that's kind of compressing that whole side of the spine and not allowing it to open. What you should be able to see with that in theory, and again, this would be tougher to do after one weekend of learning these techniques, is you'd still be able to feel some sort of decent passive glide at each of those segments. And it may not be possible because you have this overlying tone. The other possibility is that this, what Dave's calling key segment or keystone segment that's dysfunctional, is that it's not just a joint issue. It could be an intersegmental issue. There's components of this that we haven't talked about yet where we can have lateral shifts or anterior shifts or rotary shifts that will essentially create these very bad kind of motor tone issues, but it tends to be super segmental because it'll affect multiple levels of the multifidi. The multifidi, as we get more superficial, becomes multi-segmental, right? The deeper we get, the more specific it is to one level. So that would probably be the other thought that I have, is that there's some sort of lateral shift that's occurred. They're actually really pretty common. They tend to require that there be some laxity within that segment to begin with, just to allow, because it's a non-physiological movement where we have a segment that's kind of shifted over on top of another one. So we have to expect some breakdown within that segment to begin with for that to be possible. Now, dancers, I've worked with them a lot in my career as well. They tend to be very mobile to begin with. And if they're, anywhere over the age of maybe 16, especially, and they've been consistently doing this stuff, there's a decent chance that they have some laxity in one of those segments to begin with. So that's definitely possible. We could talk more about how you find and treat those sort of things as we go along, if we have a few minutes to do it. Because it is different than looking at a simple facet joint lesion.
Yeah.
So those would be my thoughts.
Yeah, it's in line. That's
Perfect.
where
She is like 25.
Yeah.
She is like 25. She's been in her professional career for probably 8 years now. And then she is scoliotic as well.
Well, and that would make some sense because, and scoliosis is one of those things where it's just like, yeah, when you're looking at it in isolation, right? Somebody takes an X-ray picture. We've talked about this before, where it's like, this is a static image. It's just showing where these things are resting in space at that moment. So I'm not always as concerned about seeing that sort of stuff or, reading about that sort of stuff in a history, because it's possible that some of these scoliotic changes are just being held in these positions by overlying muscle tone problems. We see that sort of stuff a ton, where if we have a shift, some sort of ring lesion or some sort of rib lesion, something like that through the thorax, is we'll get these kind of local scoliotic curves, and then the body has to adapt to that as it moves either up or down the spine. So we see that sort of stuff all the time. I'm more interested into whether they can get into and out of the positions that they need to, right? What does their active motion look like? What do their combined motions look like, which is really going to give us a better idea of end range mobility for these different joints. So I don't get too worried about that, but it might suggest that there is some wear and tear, and certainly 25-year-old dancer, that's a lot of wear and tear, right? And my
So much
guess is she's, yeah, my guess is she's had back problems in the past as well. I'm just guessing on that, but that's a pretty common problem, and it's, you know, profiles well to some of these shift issues that can kind of crop up from time to time.
Yeah, it was in the lumbar segments, right? Did I get that correctly?
I think so.
There's a thoracic. Yeah, 'cause when you mentioned scalenes, I was thinking cervical. It's like, God,
Yeah,
did I
it
misunderstand?
was the lumbar segments, and then Eric, you're right. This is why. And Eric, you are right. This is her, my friend being the head physical therapist at this company. In all 3 seasons, we've battled some level of an acute on chronic back situation.
Yeah. Yeah, to me, sometimes that just screams of these shift issues because they can sit there as like ticking time bombs, right? Because what do we get if this thing shifts over? And really it's this, and there's probably some rotary component to it. Um, it puts absolutely every tissue in that segment on some sort of stress, whether it's a compressive stretch or compressive stress or tension, stress. These sort of things, it doesn't take a lot to set off an episode, and all it needs is one particular tissue to get damaged for it to set off an acute issue, even if there is kind of this, you know, underlying chronicity to it. So I see it all the time. It's one of the, what'd you say, missing link type of things that I
Yeah.
start when once you start treating something like that, it's just like, oh, it's, but the problem is it's the whole segment, right? It's not an individual thing, so it can be bilateral. It can produce bilateral, you know, reference into the legs. One of the major things that patients that have this will report, and I look at this as a pathonomic sort of thing, sign or symptom that a patient will report to me is they have a difficult time going from sitting to standing. So once they get into a standing position, it'll feel like they're kind of being pushed forward. They have a hard time getting their hips underneath them. And most of the time that's due to the spasm or the increased tone in the psoas, whether it's on one side or both sides. But they feel like they're kind of always trying to catch up to themselves when they're walking. Their trunk feels like it's out in front of their center of gravity. That's a very common complaint. One of those things when I ask them that, and I'll ask them it specifically, if they say, yeah, that's definitely how I feel when I'm getting up from a chair or getting out of the car or whatever. I say, okay, you've got to shift. It's going to be there. It's just a matter of, you know, what level it's at, how significant it is, whether it's compressing neurological tissue, if it's just nociceptive somatic type stuff. But they're real common problems. You know, like I said, we can go into the in depth more of what to look for and kind of how to treat it as we need to, or if we need to have a separate conversation, we could do that too.
Yeah, a few things we haven't gone into, like scoliosis. Are you looking at SI joints because the sacrum is going to torsion down? That would be a big stressor on one of these segments. TL junction. You know, if you're looking at bulbar right or bulbar below, potential drivers. So there's some other things that we haven't had a chance really to get in depth with yet. We didn't touch the sacrum as much because you can do a ton of it in the next one. But there's a gapping move you could try, but you know, really then you're shooting in the dark. The only thing I would think of too, if you find irritation that may be coming from a higher vector of thoracic spine would be to do it blindly without having covered it yet would be seated traction. You may get lucky, but I wouldn't do it with a ton of force. I would just use gravity.
Yeah.
Okay. Okay.
So you'll find
Yeah.
your TL junction, something like there, you go pick her up, seated traction, you're gonna feel a thud.
Perfect.
It's gonna go, oh, it's gonna be an app thing. And what that does is Eric's talking about there's lateral translations. What's great, it's funny about them is they're hard to find sometimes when you're new because the whole segment doesn't move well, so you don't know quite what's going on. But the fix for it is relatively straightforward.
Yeah.
And it's creating space.
Yeah, it's real easy. My suspicion would be it's going to be L4. It's pretty consistent. L4 is going to be the worst of these things because L5 tends to be stabilized in between the PSISs. So it's not going to go side to side very well. L4, on the other hand, is up above that, and that does tend to shift very consistently. Once you get above that 2, 3, L1, they tend to be so much more stable, just because there is less mechanical movement that occurs at those segments. and less stress, because the incline of the spine, the lordosis, is less through the higher lumbar segments, so there's less wear and tear on those to allow this sort of thing. It's not that it's impossible for it to happen, but very consistently L4 is the worst of it. And then it's just a question of which direction did it move? Did it move left or right? And you can do a straight, lay them on their side and just do a straight transverse shear. That's usually my confirmation test for these things. It's a stress test that we used to, well, Jim used to teach. I still teach it because I use it as a confirmation test for this particular lateral shift issue. But it's generally thought of as something that you only use in postpartum females, which I disagree with, which is fine. I think that's just how it was described in the literature, but it tends to work very well. And you'll find this very rigid end feel where there's no give in that particular direction. Whereas if you go the other direction, number one, if you go the other direction toward the direction of the shift, it might reproduce pain, or you might get spasm. But at the very least, you would still feel the ability of it to move. Whereas going in the opposite direction of that subluxation, it would feel completely jammed. And that would probably be the one thing that you could do where it's just like, oh, okay, this is pretty easy. I've never had, even patients that have come in with severe pain reaction, because these lateral shifts can be some of the most painful lumbar pathologies that we find outside of true disc herniations. And realistically, the only differential diagnosis that we have to concern ourselves with when we're considering a lateral shift is a contained HNP, right? So one where the annular tissue hasn't failed yet, but there's a herniation within the disc itself. Those are exceptionally painful and they act very similarly. The difference is when you try and correct the shift, the contained herniation is going to hurt like hell. The lateral shift, they feel almost nothing, even if you're pushing it, leaning over the top of it. I've had patients where I'll sit there in that position and I'll just lean on that L4 segment and just kind of let it slowly drop back into its position. And I can push on it as hard as I want. No, it doesn't bother anybody, even if they're in a very acute pain state, which is nice to do. I would say the more effective long-term treatment is long traction, right? So being able to do a lift technique in standing to let their hips drop and pull the lumbar segments downward. And that's going to get you to do kind of this thing where it's going to lift and drop it and kind of self-correct that stuff. It's kind of like a gapping technique, but it's not really, because we're not really gapping a joint per se. We're just trying to get things to kind of line up a little bit better. The problem with that early on is that we typically have so much muscle tone going on, so much reactivity in the local paraspinal musculature, the QL, and particularly the psoas, that those drop techniques don't work very well. There's so much tone, we can't just get it to give. So that typically the side lying technique is going to be more effective. And like I said, it's pretty easy to do. It's just a matter of putting them in kind of a neutral position, trying to take as much pressure off the spine as we can, and then we're just trying to kind of see if we can get that segment to shift down. And if it does, great. Then we flip them over and we try the other direction. One of the directions will likely be restricted, but it's something you can check on. It's pretty easy to do. Now that we're off on like a tangent.
I know, some of the may seem really new, but again, it's going to get much, much easier. Not to keep punting it down the line, but just kind of it's a little advanced technique for where we are. Because you saw I jammed as much into you as I could in that period of time. And we'll just continue to kind of build on that. But yeah, just reach out to us either way. Let us know. Reach out to Eric. We can always kind of send you one of the videos that are in the upper modules.
Yeah, I think I have them somewhere. I'm sure I have them on my computer here.
Perfect.
Down here. All right, let's think case wise. We'll go over this. Yeah, I sent you the articles and I put a link in the chat box for those of you who aren't getting or not getting the email to these notes. And basically what it is it's really kind of looking at cases and differentiate. We're doing one lower extremity, but then we're also going to take this model and then look at an upper extremity case just to see that it's really understanding the differences between these. And again, we're applying it in the upper extremity and lower extremity. There are some subtleties, how we look at it differently in the upper extremity rather than the lower extremity, but we can kind of go over them as we do this. There. So think about a lower extremity case, differentiating referred, radicular, and neuropathic pain. 42-year-old male warehouse worker. Chief complaint is deep aching in the posterior thigh and lateral calf. It is aggravated by prolonged standing, sitting. I see gradual onset over 3 months, no traumatic history. Quality is deep, dull, posterior thigh and calf, occasional burning pain with prolonged activity. Pattern worse with prolonged standing, and lifting relieved with sitting and lying supine. Occasional tingling in the foot. Answers and stretching give mild relief. So you see a very general, but a very kind of common case that we see. So Patrick, what will be your first step in differentiating these conditions?
Patrick's probably sleeping by now.
He should be.
No, I'm still here.
Oh, that's a first.
Amazing. First step in starting to differentiate. We would start going through some possible active range of motion, seeing what increases or decreases pain with specific motions.
Yeah. Give me like an H1, like as an example. And again, it's wide open here. Pick, okay, you get this bit of a history. You got a bit of a mixed bag of some symptoms here. Give me a history. Okay, this is a somatic pain or a nociceptive pain. What do you expect that to look like?
Well, I'm leaning towards more somatic pain in the way that it was a gradual onset. No traumatic injury.
Okay.
So H1 would probably be a biomechanical dysfunction.
Okay. And how would that look as far as like going through the different tests? That was the case. What would this look like for straight leg raise? What would you expect?
For straight leg raise, it's possible that we would get some symptoms at like end range once we start to put stress into the lumbar spine, but probably no reproduction of pain until that like 60, 70 degrees of motion.
Yeah. Similar thing with the slump test. What would you expect with the slump test?
Probably negative.
Good.
Possible at end range, they might get some of the symptoms.
What do you think? Neural tension testing? What would you expect to see? And what would you expect to see if it was also radicular neuropathic pain? What would be the differentiator for you?
If it was neuropathic, we would probably be positive with straight leg raise test.
You already said it. Sorry.
A quicker positive.
I meant palpation, not a neural test. I'm sorry.
Palpation, probably some tenderness, maybe some increased muscle tone.
Yeah, like the somatic or local pain, you're gonna expect more local back pain or there. If you have like they say ectopic firing of the dorsal root, and you're getting lancinating calcalgic pain, and you're gonna have hypersensitivity and distribution through the nerve, which is that allodyna. More radicular type symptoms. There may be no tenderness in that area. There may be some light facilitation of some of those muscles if it's gone on a while. And again, you're going to have positive neural tension with palpation. With the somatic or nociceptive pain referral, you can have, that's where you're looking at, okay, you may have trigger points that are referred into the gluteal region or upper thigh, and then local pain in the back. Cool. Myotomes.
Myotomes probably pretty normal, fairly strong with testing.
Yeah. How about with radicular symptoms?
Radicular symptoms. If it was a radiculopathy, it would probably be a breaking weakness.
Yeah. And commonly what you'll see too is if it was like, if you have neuropathic pain going on, there could be some ectopic firing in that segment, but you can have severe pain. But sometimes the myotomal weakness can be inconsistent, which is a bit of a kind of a head scratcher, because here you have this person with very calcalgic, very, very severe pain, but you may not have the myotomal weakness associated with it with that ectopic firing. Usually it's going to be pain inhibition before you can test the myotome. I saw somebody like that just yesterday in the upper extremity. But they're in so much discomfort with that it's really it's hard, your basically pain inhibition is your kind of threshold. Really, for distinguishing these, it's really kind of important the qualities of pain between nociceptive and neuropathic pain. That burning electric calcalgic like thing over the far end of neuropathic pain. Whereas, it's going to be intermittent with nociceptive pain. It's when tissue is loaded. It's more antalgic. There's postures that can increase your pain. There's postures that can reduce it with the nociceptive pain. You may also find that a bit with neuropathic pain if you get pressure off the nerve, but it's less consistent and mechanical. So as we go in that thought process, we were thinking, are there mechanical properties to this that can reduce or increase the pain pattern in this individual? And as we talk in those testings too, like in myotomes, you don't touch on segmental facilitation in there. You may have that in that somatic nociceptive one, and it can also be to a degree in the other ones. It's probably going to be slightly overshadowed by the severity of symptoms. And Eric, if you have any thoughts on that, what you may be seeing in clinic.
Yeah, I mean, the problem with it is when we went over and talked about our force output testing, right, is the more severe the pain is, the more likely we are to just find inhibition from pain, right? So even if we're having neuropathic pain, if the stress and the stimulus on that neurological tissue just to fire itself, we may have pain inhibition on the very first test, right? We usually do 5 or 6 repetitions with this, but if the first one's positive, we can't test any further. So we can't look for true myotomal weakness from a radiculopathy because there's no way to test for fatigability if you can't test it more than once, right? And it's the same thing if we're suspicious that there's an underlying facilitation. Facilitation tends to require repetitive, speed-dependent testing in order to find that as well. We can't get to repetitive testing if we have this pain inhibition, if it's severe enough to have neuropathic pain. I will say in most cases, there's kind of 2 different stages to a facilitation. There's kind of an electrical phase where we're just getting increased electrical output from these nerves, that pool of interneurons within the cord, within the spinal column. They get wound up, right? That takes less effort, less depolarization for the nerve to fire, so we get increased electrical signals. But there comes a point where it becomes chronic enough that we actually chemically change the synapses and they become more sensitive to less stimulus at that point, right? And so when that happens, there's probably no ability to reverse this sort of stuff. I don't think there's any real research. I've looked for it for years. I've never found anything that suggests there's a specific time frame or a specific amount of stress that's required for us to kind of transition from this electrical facilitation to more of this, kind of molecular chemical type of thing that changes the synapses. But it's probably something that we see in situations like fibromyalgia and some of these other, complex regional pain syndrome, some of these sort of situations where they are much more chronic as these synapses have changed. And that's why we can help improve these things, but we can't ever cure them because this has become a structural alteration to these things at that point. But yeah, it sometimes it can be a little confusing because I think any consistent chronic stress that lasts for more than a few weeks is probably going to start winding up the segment for potential facilitation. But neurological symptoms, that's going to tend to overwhelm the facilitatory effects, right? Because it's going to affect the conduction output. And when that happens, we're never even going to get the chance to test for velocity dependence. But we do see this consistently if we have a patient that comes in with radicular symptoms and we're able to alleviate those symptoms, which has its own challenges in doing that on its own. If left untreated going forward from there, we can eventually develop a facilitation because now we have abnormal stresses going through that segment because of changes to the mechanics of it, right? If we have a posterior lateral protrusion that created some inflammation in and around the nerve root, it initially presents with radicular symptoms while we, go into our usual routine here, do some, prone compressions, some unilateral compressions, things like this to help flush the inflammatory exudate out of the area. That helps to eliminate the chemical stress on the nerve. and, helps to alleviate any potential radicular symptoms, the neurological stuff that we would see, fatigable weakness, loss of sensation, etc. But if we leave the mechanics of that there, if that mechanical vector is still affected because of that posterior lateral protrusion, it's just in the way now. It's just a mechanical block. It's still going to overstress and create abnormal strain to some of the various tissues around that. Over time, that can develop into either instability and or facilitation, right? So any kind of abnormal stressors, whether it's proprioceptive or nociceptive, can start to do that sort of thing over time. So it's definitely something that we have to be conscientious of, like, oh, okay, we're getting to the point where we're treating a patient and their radicular pain is going down. We're able to centralize that sort of stuff so that the peripheralized pain, the radiating pain is improving. Well, that's not necessarily the end of the road for this person, because we want to make sure that we get to the point where we can help stabilize that segment, alleviate any additional stress so that it doesn't progress to an instability and doesn't progress to a situation where there's facilitatory effects that are going to, potentially cause additional problems down the road. Because, essentially, if we're dealing with, say, an athlete, they hurt themselves, they're doing some lifting, doing something at high speeds, and okay, they hurt their back. We get them back to the point where there's no radicular stuff, but all of a sudden they go back and they're doing these high speed things under load, with multiple vectors, rotational things, all these different forces acting on the spine. If they have these speed dependent weaknesses, we could end up with an issue, helping to stabilize a peripheral joint like the knee, for instance. And that's going to cause whole different issues down the road. Now, nobody may ever make that connection, but it's definitely something that we should be able to take into consideration and say, this is why we want to do these things to get you to this point so that we don't have these other potential issues down the road.
Yeah, that's where it's early buy-in on the plan that you set to know that, hey, you're going to get a point where you're going to get better, but this is where you need to get to that phase 3 to, make sure you're working on hypertrophy. Your system knows to recruit and get the right timing. We just haven't relieved the pain, but now you have a gimpy pattern. Then your gimpy pattern turns into atrophy or fibrosis. So setting that up early. If you try to do it at the time when they're feeling better in there, you're kind of already later. They heard that message early on that, hey, we need to keep doing that. It resonates better when they're in that painful pattern, because that's when they really want to kind of I want to get back to good and make sure this doesn't happen again. As soon as we feel better, we're kind of like ready to go and kind of do our thing. So make sure that it's like telling them the full story as early as you can will help with getting buy-in. And here's a diagram from the article over that I sent over, which is kind of classic, is two people with the exact same symptoms. One is going to be neuropathic and one is going to be referred pain, where we see the pain pattern going down the leg, the pain scale is the same. And again, that's where we need to look at once we get into there is the qualities of that pain. Understanding very early on somebody's coming with back pain, I'm trying to sort through these two things generally as quickly as I can, because that's going to tell me the story of where I'm going next. If it's burning and tingling and pins and needles, if I'm getting, lancinating electric shocks down my leg, certainly that's going to make me think one way versus this dull, diffuse achiness, maybe non-specific, patterned with movement patterns. I move a certain way and it makes it irritable. That's kind of some of the things we'll look at when we want to differentiate. Okay, when is it I'm looking at neural tissue versus nociceptive or somatic, as we kind of use them somewhat interchangeably now.
Yeah. And sometimes it's going to be inconsistent, right? Sometimes with somatic pain, it takes repetitive stress in order for it to instigate the pain response, to the reference pain in the first place, right? So they may have a situation where it's just like, God, I was doing this thing and every time I'd bend forward, it would create this pain. But, when I wake up in the morning and I bend forward to put on my socks, it doesn't hurt me at all. It's like, well, yeah, the first time you do it first thing in the morning, it's only one movement. It's only one particular load on that tissue versus if you're bending forward all day long, doing work stuff or lifting things or whatever it may be, repetitive stress starts to produce that reference pain over time. So it's a summative effect, a cumulative effect at times. So to them, it seems inconsistent, but you can kind of recognize like, well, it's consistent once it's irritated, but sometimes it takes a cumulative stress to get it to the point where it's reached that potential.
And going back to the case, like we also Lizzie talked about even initially, is that Okay, with that case, okay, we're thinking pretty quickly that this is biomechanical and local. We're not really seeing large scale neural signs of this. Like, okay, if it was a little bit higher up in her thorax and she's getting pain that's wrapping around her rib, then I gotta tease out, okay, it'd be rare to have a thoracic disc, but then my mind goes, okay, thoracic disc with radiating pain around the rib, but the quality of the pain would matter to me. Then certainly the biomechanical exam. In the lumbar spine, once you give that history, and we all quickly filtered through in our mind that, okay, this didn't strike us as, oh, this is a posterior lateral disc, that's referring to pain down the leg with radiculopathy. We got in there pretty quickly and think, okay, this is nociceptive somatic style pain with a lot of muscle, with some muscle guarding. And then that information then tells me that, yeah, I'm looking for then what's the key segment that's probably doing this. Eric talked about, there it's, we're on speculation. You think about the high probabilities, L4, L5, because of the movement it has versus L5, S1 and the rotary dysfunction. That is something, those rotary dysfunctions will be something that will light multiple systems up. But just kind of thinking how we're processing this information constantly. It's just framing it in our mind so we have a context. Okay, a 55-year-old female office worker, right-sided shoulder pain, radiating down into the lateral forearm and hand, index fingers. Oh, go the board here. Courtney, what does that make you think? Lateral forearm, hand, index and middle fingers.
So I'm thinking either cervical disc or obviously the nociceptive pain. So either one of those is what I'm thinking. My first thought would be is rule out radicular or neuropathic pain from a disc.
Yeah, and that with going to the fingers and having a clean distribution, that's kind of where my head would be first as an H1. But you're right, in there you have your H1 and your H2, but you're on the right side is the right frame of thought. Think about what am I going to test first as I get into it there.
So yeah, I would first test for neurological signs.
Okay, let's say this was, what level do you think this is?
Lower cervical.
Okay, what level do you think this is?
Specific. I got to go back. What was it? What fingers?
Let's go index finger and middle finger. Again, there's some overlap in here, so there's some reason to be generous.
C6, C7.
Okay, well, you're narrowing it down a little bit more. Okay, if it was C6, what key muscle would you test? Oh, it's hard. Oh, we haven't done this yet.
Biceps.
Yeah. Nope. Biceps.
Right? Yeah.
Oh, don't tell me biceps. But here's the problem this is a soapbox
He's
issue
getting on
that I
me.
have.
No.
This is a soapbox
You're
issue I
doing
have with
fine.
the
We're having
biceps.
fun
I
with
have the
you.
same issue with the quadriceps because it's split almost 50-50 between 5 and 6. Right.
Mhm.
So if we have a situation where we know we need to lose 80% of the available motor units to test for fatigability, test for neurological weakness, but only 50% of the muscle is supplied by C6, we're never going to get down to that 20%, right? Because we're always going to have that 50% from the other level. It's the same thing with the quadriceps because we're going to be pretty close to 50-50, 3-4 for the quadriceps.
Yep.
So they're just bad key muscles because of the split innervation. So you're right,
So,
it's part of it, but it's just not going to be a good one testing for fatigability.
Where do you test for your
brachioradialis.
C6?
Supinator.
All right.
Supination, brachioradialis. Would that be more
Wrist flexion or
C6?
extension for bonus points.
It's better for C6, sure.
Right? Yeah.
But you're gonna get a lot of supination coming from the biceps as well. And you're gonna get a lot of elbow flexion coming.
Sorry, I
from
saw
the
all
biceps.
pelvic health this morning.
Mhm.
I'm thinking, I don't know. I'm gonna say I don't know.
That's okay not to know. So 6, a good one would be wrist extension.
Okay.
Okay, wrist extension would be a good one for 6. There's actually a lot of them for 6. So shoulder internal rotation, the subscap is a really good one. I particularly would like subscap for this particular situation because one of my primary differentials for this is going to be a radial nerve issue. So if I have potential radial nerve issue, doing wrist extension is going to give me both C6 and the radial nerve. So it doesn't differentiate anything for me. Shoulder depression's another good one.
Mhm.
Serratus is another good one.
So yeah, you'll see a blend over into these patterns. Do it. Like for me, all right, I'll run through these as I test it. And if I see that there's weakness in the biceps, then I want to see it also in the wrist extensors. So it's like usually a pretty clean match when you kind of come up with it there, that you'll see this pattern develop as you do it. Like you may pick it up there, but that's usually what I'll end up seeing. The biceps is nice from a party trick standpoint, because as you start to do it and you break them, then you kind of can taunt them. Well, I'll taunt them a little bit as I do it, because I then know, okay, can I go back and kind of see it? But they see that one more. Like they may not notice they'll notice their wrist, but it won't be quite as dramatic to them there. But that's what I do, is I work through those muscles knowing that, okay, here are these key muscles. Same with like a triceps. Like I'll do triceps, but then I'll also do, again, chest and wrist as well, or flexors. And you should see that the pattern develops.
Is there another potential null hypothesis we should be going to look for based on one of the other symptoms this patient complained about? Remember what a null hypothesis is, everybody? Medical diagnosis?
Heart attack, cardiac,
Yeah. So because of what? Which part of it makes you think that?
shoulder blade pain.
Yeah. It's on the right side, but that doesn't necessarily rule it out.
Hmm.
So what part of their pattern here is suggestive that that's not the case?
There's a functional pattern that it like worsens with certain activities and reaching overhead. So that's not typically cardiac.
Correct.
Like that, it's an
Yeah.
activity.
Yep. So that's a good sign, right? But the shoulder blade pain, the interscapular pain, also tells us something else. What does it make it? What makes it? When I mentioned some of the other possible differentials, what makes it less likely that radial nerve issue? Let's try and tap the screen.
What makes it less likely in her complaints that it's not a
That it's not a
radial nerve?
radial nerve, not a peripheral nerve problem.
Because it's coming proximally.
Because there's interscapular pain. How would the radial
Yeah,
nerve
yeah.
reference pain into the interscapular region, right? So that makes us
It would be
more
distal to that.
confident. Yeah, makes us more confident that this is going to be a cervical problem,
Mhm.
or at least have some cervical component to it.
Yeah, and then you can look at the T5 segment, but you can also have like Cloward's areas, which is going to refer pain down into that interscapular region. So the T5, then it's a matter of, okay, is there something going on here that's part of it, or is it just referred pain, from there, from the Cloward's areas? Most people don't know it nowadays. They don't seem to talk about it much anymore, but the cervical spine segments will refer down, almost segmentally down into the thoracic or interscapular region.
Yeah.
And they'll get these spots in there.
And 6 is probably the most common one, if I'm remembering right.
Mhm. So can you
What
see
did
there's a
you
lot
say
of
that was called? What did you say that was called?
Cloward's
Cloward?
areas. Yeah. And you look it up and think, oh yeah, I've seen that before. Once you get it, and you're like, oh yeah, I've noticed this over time. I just didn't quite know what it was or didn't put it together. Or they're complaining of the Cloward area pain, and it's a cervical case. Their pain is in their thoracic spine, but as soon as I see it in the interscapular region, certainly biomechanical, looking at the mechanics of the thoracic spine and scapula, but I need to look at the cervical spine almost in every case, because cervical spine is controlling the scapula anyway. So I need to know what's happening in the neck if I'm looking at an interscapular pain.
Yeah, it would hurt with different things, right? So
Mhm.
if it was coming from the thoracic region, I'd expect it also to be painful with some sort of trunk movement, right? Forward flexion, backward flexion, rotations, inspiration, expiration, rotation of the head,
Mhm.
potentially, things that are going to move those thoracic components more consistently. But if it's worse with, we're starting to see here on the findings that it's,
Mhm.
worse with cervical compression, it's worse with a Sperling's test. Okay, these are tests for the cervical spine, stress the cervical spine. So again, we're building our case here, right? We're looking for proof that we're going to start treating the right area.
Okay. Paul, talk me through it. Like here we're seeing what the positives are. Tell me what this looks like if this is a biomechanical dysfunction. What's your cervical compression test and your Sperling's test likely to be?
If it's biomechanical, I would say those would be negative.
Oh, you're a very good reader, Paul. Good.
If it's like
Pal.
nerve related or radicular, that's positive because you're just compressing on that specific spot.
Yeah, and okay, well, talking about palpation, they're gonna go with trigger points. So we go, okay, trigger points are classic. They have upper trap, rhomboid. I put levator scapulae in there. You can see a number of different trigger points that are in there. Well, let's go into palpation a little bit deeper. What would you think you would find at the C6, C7 segment, or if in this individual, or C6, C5?
I guess I would probably expect to feel more tone. I don't know how sensitive to be around that spot.
They kind of got the muscle in there. You may have some hypertonicity, you may have some inhibition, but generally you'll probably see some hypertonicity around there. What about the joint?
With joint mobilization, if it's I guess
this is wide open. You can speculate here, so don't be afraid to say something.
I guess I would anticipate I don't know, maybe because of the muscular tightness, the extra tone, you would sense that it's less mobile, or there'd be more of a muscular end feel if it's more guarded.
Yeah. What type of articular end feel might you have? That's a phrase you'd use in the lumbar spine.
Type of articular end feel.
Put it here.
If we're assuming it's
what could cause these let's say causing these symptoms? They're getting pins and needles down there. What could be happening that's not a disc or acute inflammation that may give us these symptoms into the arm?
I guess if there's facilitation, if there's
Facilitation. Think of an articular restriction. Okay, if I have something that's going to close down the foramen, it could potentially kind of lead to this, like a narrowing of the lateral foramen.
Sure.
It really depends on the axis of motion of this joint, which one may do it. But you could have a subluxation, let's say it goes into extension and side bend, so it could close the foramen off. It all depends. This individual is 55 years old. So chances are what you're going to find this individual is, Paul, you remember the ancovertebral joint is? Okay to say no. Okay. Ancovertebral joint, it's the interbody joint that forms laterally. In these individuals here, that joint is going to be getting fairly arthrosed at this point, and they will likely have a restriction there. Now, the bony incropping that closes off that foramen can come from, basically, osteoarthritis of this joint is a very common one. So, general rule of thumb, people over 50, they'll talk about having this, quote unquote, something called a hard disc lesion. They get bony encroachment into that space. Younger people tend to have more like the soft disco. They're soft disc lesions, which is the disc that we tend to think about. And we'll talk more about the biomechanics of the disc later, because it is different than the lumbar spine. But this person here, 55, could be some bony encroachment or some lateral stenosis going in there. I would often say we're going to see that problem occurring at the ancovertebral joints limitations, sometimes more than the facet joints limitations at this area. And Eric can kind of agree, disagree, give some thoughts on that one.
Yeah, I mean, honestly, I think the ancovertebral joints might be one of the kind of most overlooked parts of the body. We tend to think about the facet joints a lot when we're doing mobilization for the neck, but very few people that and this is, not specific to this group, obviously, but most of the people that I've taught how to do these things, it's like, oh yeah, kind of forgot that that's part of the mechanics here of the neck, and they function together. So you can't really have one working poorly and have the other continue to work well. whether that's unilaterally or bilaterally, right? So the problem at the right uncovertebral joint is going to affect the left uncovertebral joint, right? And it's going to affect the facet joints as well. The difference is just that the uncovertebral joints, they do tend to fibrose, they do tend to become degenerative more quickly just because they have a greater loading stress because of the weight of the head. The facet joints are not supposed to be weight bearing, right? They tend to get weight bearing if we get into a forward head posture as we take the angulation of those facets and all of a sudden we drop them into a more of a horizontal plane. But the uncovertebral joints are always under weighted load, right? That's just the way that they're put together, at least when we're upright. So they do tend to break down a lot quicker, I think. I think you're right about that.
So that's when it considered like palpation as we get into our biomechanical pivum and pavum. Radicular pain in this individual, that's another thing too, as we see this, and maybe no significant muscle tenderness. Certainly I expect positive, whether it's muscle guarding, or likely I would expect what I'm hoping for is, do I have a lateral restriction that feels articular that is treatable? Is it a lateral stenosis? And what I need there is millimeters of clearance. Can I get this nerve root to free up, or the stress that may be put on it to come up? Now, this is not going to be the super hot person. This is that person like with a gradual onset. I'm feeling better about it. Do I have this gradual kind of compression or irritation of the nerve? If I can get the segment there, the segments around it moving better, can I free this nerve up? Millimeters of clearance is kind of what we need. So this isn't an acute onset of, boy, I was, doing yoga and doing headstand practice, yesterday for 2 hours, and now I'm having all these large symptoms. As somebody who's done the acute event, there's inflammation, there's something bigger going on. Someone's a gradual onset. I start to think, okay, can I biomechanically influence this in a positive way? So the pivums there become kind of valuable to me. That individual who is neuropathic pain that's a much harder road to go. You may not even be able to get into the end field without a spasm or an empty end field because of pain.
Yeah, that's one where you have to kind of work your way into it if you're lucky.
Yeah.
Be able to work your way into it.
Yeah, so that's a long view kind of a thing. Like, hey, can I desensitize them enough so that I can do that at 40 minutes into the session? If I can do it then. If not, it goes to next time. I had one yesterday, was neuropathic pain, and it was causalgic. It was severe. And, I was working with another PT, they didn't want to, they were afraid, they didn't want to do anything to the neck because the pain was so severe. But on her, I could go in and do segmental traction and take it all away. Problem I have there is a source I know as soon as I release it, I'm going to put that compression back onto the nerve. But it is helpful for me to see that, hey, I can do segmentally specific traction in a lateral glide. I can get the pressure off the nerve and take those symptoms out of her hand so she can move her hand around, because she was looking like somebody who's developing a lot of central sensitization from that neuropathic pain, because it is such a strong stimulus and you start to see that cascade. So me being able to take the load off of that nerve, have her be able to move her hand or arm, desensitize, there's some value in there. But then becomes is, how do we kind of, get this when this person sits up and the weight of the head loads it? How do can I posturally adjust her? Can I unload? The arm needs to be supported so the weight of the shoulder girdle hanging doesn't create compression. I now need to think in like 360. How do I get pressure off of this system until this cools down? And it can be, some things are easy, sometimes it's challenging. She had a couple of things which were good that we could do, but she's going to take some finesse. And a lot of patient education on this is really shitty right now. It's going to be shitty for a while, but again, statistics are on your side to a degree. And she didn't have necessarily neurological weakness, a lot of, just pain inhibition. Anytime you loaded it too much because of the hypersensitivity. So I couldn't really assess her myotomes yesterday, is how it's different from this one, where the C6 radiculopathy, we have C6 weakness. And again, as we do that, it's qualifying the weakness in these individuals. If this is, no paresthesias and I have non-fatiguing weakness, okay, do I have a facilitated segment, like a radiculopathy light, as it were? With that, I would probably expect that if it was a segmental facilitation, I would expect that compression and Sperling's test might be equivocal. You may have mild local pain, but not reproduction of the radicular symptoms. That's how I think about segmental facilitation, and we can add this to the chart. And again, what I expect here is dermatomes to be positive, and upper limb tension tests, you probably won't get very far with them before they get hot, especially in the neuropathic pain. Again, here's just kind of talking about just ruling out, referred pain. That's, you're really looking at your neurological assessment. You're finding, just the symptoms where they are, and then ruling in the same thing. They're kind of reversed in a way, If I have no spontaneous burning, allodynia, widespread nervous system pain, symptom change in neck position, increased pain, that's a mechanical trigger. So like you don't have to, both of these things kind of help to rule in and rule out each other based on symptomology. Neuropathic and radicular pain. Eric can speak this too. You look at this, it's kind of like a sliding scale in a sense. You're going to have some people come in with just radicular symptoms. That's that I have paresthesias, pins and needles going down to my lateral thigh or my lateral calf and into my lateral foot, versus that person who's I'm getting an electric shock and burning like somebody's holding matchsticks to my leg. The one is neural irritation. The other one is ectopic firing of the nerve. So the nerve gets irritated or damaged, you tend to have more the radicular type of symptoms. If you're getting ectopic discharges because the nerve has been damaged, you're going to get the causalgic pain, the allodynia, the much stronger symptoms. And then those things that Eric talked about that leads to that cascade of that central sensitization and, may possibly leading to some of the myofascial pain syndromes or chronic pain syndromes.
Yeah. Yeah, I always think of radicular pain as kind of a subset of neuropathic pain. It's going to originate more from that nerve root compression, irritation, sensitization from inflammation, things, that sort of stuff. But it's going to have that dermatomal, myotomal distribution to it. Neuropathic pain is going to encompass a lot more. It's going to be a broader category where you're going to have things like diabetic neuropathy and, post-herpetic neuralgia, multiple sclerosis, and, stroke and spinal cord injuries and things of that sort of stuff that they may not always follow a true dermatomal or myotomal pattern, right? They're going to have kind of these abnormal, at least from a segmental perspective, they're going to look abnormal reference patterns, but they're similar in that the pain responses that people will get will have these kind of immediacies to them. Some of them can be more based on mechanical movement. So radiculopathy, if I have a posterolateral herniation in my lumbar spine and I bend forward, bang, I'm going to have that radiating pain that's going to shoot down the back of my leg. It's going to be instantaneous with movement of my trunk. Same thing if I have foraminal compression here in my neck and I go into a Sperling's position and create more compression, zing, there it goes right away down the arm. That's consistent with radiating radicular pain. Neuropathic pain may not follow the same sort of suit just because it may not have a true mechanical trigger because of things like diabetic neuropathies and some of these other ones that I mentioned. They may have pains that are very similar, still these lightning bolt burning, electrical type of pains that can produce, but they'll be in different body regions and they may be more spontaneous and inconsistent than what we would expect with a true radiculopathy. So again, you're looking at a radiculopathy being a type of neuropathic pain, from my estimation anyway, but it's going to be reproduced by movements of the trunk of the spinal region that's going to be affected from it. And it may not be the same case with, overarching neuropathic pain.
I put in other case examples going into more central sensitization and complex pains and overlay there. And I figured we had no chance of getting to them, but I wanted to kind of give it to you just so you could kind of start to play in those other concepts to see, okay, where do these fit in? Because there is a great deal of overlap. Like the last case I put in here has somebody who has a mixed bag. I think it goes over a case where, yeah, you could have components of each one of these things. You can have nociceptive pain with radicular pain and phasing in neuropathic pain. A lot of patients we see are coming in and out of these things. That central sensitization, we're hoping is being driven by one of these things, and that when we remove the stressor from it, that neural system can unwind. It doesn't become hardwired into the system. which is going to create your chronic pain syndromes, is what you're looking at. So these cases kind of do it. And as you see, it's like whether we make it the upper extremity or the lower extremity, we're really looking at the model is the same and how we think about it. That's why I wanted to kind of do an upper extremity and a lower extremity case to see it, though there'll be nuances because the cervical discs are different than the lumbar discs and what may be driving it or what may be generating it or how it degenerates due to the oncovertebral joint. Good. Fred will be happy. This is something that we really kind of, if you can get a handle on this, it's very, very helpful in fast thinking in the evals. And when you're seeing people that really kind of set which direction do I need to be going in and knowing when do I need to pivot because this patient changed. And it happens. They'll start one way with something and then they'll pivot to a nociceptive pain or a radicular pain and, be ready for that or accepting of it when it happens. Cool. I will get out the rest of the schedule in the next day or two. That way you have it. Then we don't have to rely on me missing an email so that you have it coming up for the lead up to the thing. So I have it pretty much ready. Just want to finalize one or two of the articles I was going to include. And we go from there. Eric, Fred, we'll catch up sometime, maybe early next week.
Yeah, I think that's a good idea.
Okay. Anyway, shoot for the Monday. That's cool with you.
Should be able to do that. Yeah, as long as it's not late in the